There is this term called Mommy Makeover, where they can tighten the skin and everything.
Gynae, when we do, we call it as cosmetic gynecology. Changes happens at the breast level. So there is sagging of the breast. Then your abdomen, it becomes loose. It's like a balloon, which is distended, and then it doesn't come back to the same size as before.
Correct.
There are few problems also, they'll have the stress urinary incontinence. When they cough,
They can
when
leak
they sneeze,
urine.
yes. When
Without
they sneeze,
their control.
yes, without their control.
Especially in the US, there is a pill called Plan B. I heard that there's something like I pill in India. What is that about?
See, I-pill is a pill which is used immediately after a unprotected intercourse. Okay, but that is not a good contraception method, and especially in India at present, in Tamil Nadu you will not get any I-pill because it is banned. People started just randomly using it. You have intercourse today, tomorrow they'll take. After 2 days they'll have an intercourse, again they'll take. So what happens once you take that? After 2 days you get withdrawal bleeding. And then again after 2 days you have an intercourse, and then again you take, again you'll have withdrawal bleeding. You don't know when your actual menstrual period is. So then it causes lot of side effect.
You love it, huh? You love OB-GYN.
I love deliveries. Every delivery is a new victory for you.
Work-life balance. They don't want to come in the middle of the night anymore.
Correct.
What is your take on that?
When you take OBG, it is both. You are a physician and you are a surgeon. So you can enjoy both the skills.
But I think gastro is better, man.
No, I don't agree.
Why on the left side of the pill?
When you're sleeping in the left side, the uterus is tilted. So the aorta will have good amount of blood flow.
There's always a complaint that doctors are pushing for cesarean section.
Just only to break the myth that cesarean is not done for money. Cesarean is done because we want the mother and the baby to be safe.
How do you take care of your health?
So I maintain a little bit of intermittent fasting types.
Nice.
So breakfast by around 11 o'clock, then finish dinner by 9.
You
It's
follow my
only
channel?
water. I have to start following.
Hello guys, this is Dr. Pal Manik and welcome to another episode of our podcast series Gut Feeling with Dr. Pal. In this episode, we have a wonderful guest, my friend, Dr. Sandhya Vasan from SIMS Hospital, and she is a wonderful, wonderful gynecologist. She has been doing this for a long, long time. She has delivered so many babies. But this episode, I'm really excited because if you are somebody who wants to know more about miscarriages, what is high-risk pregnancy, how many times you should actually miscarry to consider as a high risk, and what should you do in case if you are having like recurrent abortions. And we also talked about how you should manage unwanted pregnancies, whether you should take a pill or whether you should go to a hospital, do a procedure. We talked about DNC risk and benefits of it. We also talked about the most important topic that what I am thinking is about consanguineous marriages, and marrying within the family risk, and also other risk factors including stress, obesity, smoking, alcohol on pregnancy in terms of like what exactly happens. And we talked about what a pregnant woman should do to have a successful pregnancy outcome as well. We talked about endometriosis, which is the most common symptom these days with increased bleeding. We talked about the treatment options, what is the symptoms, when you should see a doctor, and also there was an interesting discussion about cosmetic gynecology in terms of what are all the new procedures that is being offered to women after delivery in the postpartum period. It could be like a breast reduction, it could be vaginal interventions. All this was relatively new to me. I enjoyed the podcast. I'm sure you will enjoy as well. Let's dive deep into it. Hi, Dr. Sandhya. Thank you so much for being in my show.
Thank you. Thank you so much for having me here. Great pleasure for me to come and be a part of this program.
Oh, that's so nice of you. So nice of you. You are doing a wonderful job. Okay, so I was just told that you are in the hospital once every 3 days, despite being a senior OB-GYN at SIMS Hospital. You love it, huh? You love OB-GYN.
Yes, I love deliveries, especially when it's coming to normal delivery. It's like, you feel you have come from the victory field.
Wow.
Every delivery is a new victory for you. It's really nice. I think it's a noble profession, which I really love.
Wow. How long you are at SIMS Hospital?
Almost 2 years, from the birth of SIMS till now. So we started SIMS in maybe 2014, the launch happened. I think from that time I'm there.
For 10 years now?
Almost
10 years.
10
wow.
more.
Wow. Many medical students, they want to become OB-GYN, okay? But before they used to get gynecology like very commonly. But now they are a little bit hesitant, okay? Because of work-life balance, and they don't want to come in the middle of the night anymore.
Correct.
What is your take on that?
Yes, I have seen a lot of people, their parents will come. Like, now the trend is everybody wants to take dermatology because 9 to 5, it's like an office job. But then I feel, it's not changed. See, it's a passion how you are and what you want to be. Obstetric and gynecology is only one field where you are a physician and you are a surgeon. There's no other field. Like you take dermatology, it's only medicines. You take general surgery, it's only surgeries. But then when you take OB-G, it is both. You are a physician and you are a surgeon. So you can enjoy both the skills in one life.
Nice.
Okay, so that's why I feel it is the
satisfying.
best. Yes, very satisfying.
But I think gastro is better, ma'am.
No, I don't agree. Though a lot of gastro problems are coming nowadays because of all the eating habits.
Yeah.
But at the end
Of
of
course,
the
of
day,
course.
the new baby coming, and when you see that happiness, having a small baby in your hand,
Yeah.
you'll never get
Yeah,
that.
yeah, of course,
And the thankful people are, seeing that baby. Oh, that gratitude you'll never find anywhere.
We talked about the good things about the pregnancy, right? But there is some bad things as well, correct?
Yes.
And I have a feeling that many patients feel like once you get pregnant, the outcome is going to be a successful baby. That is not the case, isn't it? How many percentage of a normal conception can convert into a normal pregnancy or normal delivery?
See, normal delivery, it's like, once a patient has become pregnant. So what happens? The whole family, everybody the ultimate goal is that you should have a normal delivery. Normal delivery is happened now, then okay, everything is good. But I don't think that is the thing. It's maybe 50-50. When we were doing our PG and all, in the medical colleges, we are all taught that you should have a normal delivery. You should have a normal delivery rate of 85%. The cesarean rate should be less than 15 to 10%. That was a norm. But now, in the present generation, where you have only 1 or 2 kids, what I feel is you should have a healthy baby and a healthy mother at the end of the delivery. It should not be like, you should only have a normal. For a normal delivery to happen, there are so many scenarios. It's like everything is good, the baby position is good, the head is down, everything is good. But during the process of labor, also you can have an emergency. So like, the cervix should open up, the head should enter inside, the baby's heartbeat should be good, the baby should not have past meconium, that is motion. So all these criteria, when it happens, then okay, very good. You have a easy normal delivery in 4 to 5 hours you're delivering. That is the ultimate. That happiness you cannot stop. But then, if you are having a difficult delivery, the pelvis is not good, the head is not coming down, but still you force and have a delivery, then the trauma to the pelvis, because we give an episiotomy. So when you give an episiotomy, if there is a...
Explain about episiotomy.
Yeah, episiotomy is a cut. So when the baby's head is coming, so when if this is your pelvis and the baby's head is coming, there's no space for a 9.10 centimeters head to come out of the vagina. So what we do, we put a small cut. It will be either right lateral or left lateral. We put a small cut which is maybe around 3 to 4 centimeters, and it will cut 3 layers. It will cut the vaginal mucosa, the muscle and the skin. So when we cut that, the perineum becomes broad and the head comes out. But sometimes, when we're giving the cut, the baby's head might be still little more bigger. So when the baby is coming out, there will be a tear in the opposite side, or there can be a midline tear. So this tear can go into the anal region. So the rectum can cut, the anal sphincter can cut, or sometimes whatever 4 centimeters we have given, it can go inside, deep inside. So then, it becomes a traumatic vaginal delivery. So sometimes you'll have a lot of traumatic bleeding, postpartum hemorrhage we call, so PPH. So that happens because, so once a baby is come out, we may not be able to stitch it in the labor room. So we may have to shift the mother to the OT and, suture. It becomes a really traumatic. So sometimes, the baby is not coming normally. So we'll have to put an instrument like a forceps or a vacuum. So when we are using all these instruments. So that time the chances of having trauma is more. Yeah.
And there could be some birth injuries as well.
Yes. So this is from the mother's point of view. So from the baby's point of view, when we are we have to pull the baby in a particular direction. So when we are pulling, if the hand is stuck, or in a macrosomia baby where the baby's weight is more than 4 kgs, so this happens especially if the mother is diabetic. Okay, so that time the head will come, but the shoulder is broad. So then if you are trying to scoop the shoulder out, there can be the paralysis of the brachial plexus. So that's called Erb's palsy. So the baby's hand is always like that.
The nerve supplying
yeah,
the
nerve
hand.
supply, the hand is injured.
Injured.
Yes. So that Erb's palsy is very common.
And
So
how's the baby's hand will be like this?
it will be like this. Yeah, it will be like this.
They cannot bend.
And they cannot bend. But now, with the advent of plastic surgery and other things, you start the treatment earliest, you can correct it. Okay. But then that is one of the major this thing. There can be some small clavicle injuries.
The
All
bone
those
over
things.
here,
Yeah,
neck
bone.
bone.
Yes, the neck bone that can injure while you're delivering.
Delivering.
So these are and if the second stage is too much delayed, the birth asphyxia, the baby's brain, where the baby is stuck in the perineum for more than 1.5 hours, 2 hours, it's not coming out. Then the blood supply to the brain is reduced for the baby. The baby can be permanently cerebral palsy is the most common complication. So instead of having all these things, cesarean is better because there's a small cut. And nowadays, if you see, that there's a myth that normal delivery, only if it is a normal delivery, the mother will be healthy,
Correct.
she will not become fat. It's not like that. Even if you have a cesarean, within 6 hours we start them on normal diet, and within 12 hours they are all up and about walking, and 24 hours to 48 hours they're home. It's like how we have a normal delivery, same with cesarean. It's not like olden days, 3 days the patient will be on IV line. Nothing like that. It's a small myth. And whether it's a normal or cesarean, you can come back to shape if you have taken care of your postnatal period.
Postnatal period, yeah. So I'm just going to argue from a patient standpoint. Okay, there's always a complaint that doctors are pushing for cesarean section. There are multiple reasons cited. It could be for money. It could be that lack of time. What is your take on that?
It's very easy for a doctor to do a cesarean and go, but then doing the normal delivery, the gratitude what we get from the patient, definitely, as far as I know, nobody will do a cesarean just like that when the delivery is happening smoothly. Nobody will do. It's only for obstetric indication. But like as I told, we are having 1 or 2 babies. So when you're having 1 or 2 kids, if you want to have a difficult delivery, and then once the baby is come, the baby is in the NICU for 3-4 days, what is the happiness you're getting from just having a normal delivery? Okay, so that is one thing. So from a patient point of view, if they say for money it is this thing, but in fact if you see, the money is the same. Whether it is normal or it is cesarean, the doctor will charge the same. In fact, if you see all the corporates now, for normal delivery it is more when compared to that of a cesarean. Just only to break the myth that cesarean is not done for money. Cesarean is done because we want the mother and the baby to be safe and have a happy outcome. Rather than mother is there in the bed and the baby is in the NICU, you can't have your baby next to you. So definitely it is not the thing that for money they push for cesarean, or they don't have time. It's not like that.
So when a doctor is indicating cesarean section, there is a reason.
Yes,
that
there is a
either the
definite-
mother's life is getting compromised or the baby's life is getting compromised.
Definitely. So that's why I told you, people feel they took till the last, they waited and then they did cesarean. She had to undergo this pain and that pain. So then you should appreciate that doctor, that she waited till the end. But as I told, there are 4 factors which will allow us to have a smooth delivery. The cervix should open, normally the cervix, it should open to up to 10 centimeters. So once only that, if it is opening till 4 and not opening, then you can't do anything much to make that cervix open. As a doctor, we can put some medicines, but with that it's not opening, then that's all. You cannot artificially go cut the cervix. You can't do that. The head has to come down on its own. Nobody can push the head to come down. So if the head is not coming down, then how can you have a normal delivery? The people don't understand when we tell, head does not come down, that's why we are doing. What head is not come down? It is not come down, it's not come down. Nobody can't do anything about that. The third thing is, the baby's heartbeat. The baby is past motion inside. So you can't do anything about that. Baby is past motion. Within half an hour, if you don't deliver the baby will take that meconium inside. That's called meconium. That's a motion. It will take inside. Once it enters the lung, the baby will have meconium aspiration syndrome. Then it is there in the ICU. Baby will be on ventilator for 3 to 4 days. It's very difficult time for the baby. So any of these indications, I feel, don't argue with the doctor. They have given you the trial now. They have tried their best. So then once it is there, no, then better to go for a cesarean rather than have a baby in the NICU.
So we talked about normal delivery cesarean section, but there is another group where the baby may not survive. What is the percentage that normal conception leading to a healthy baby in 9-10 months time?
The percentage is high, maybe around 90-95%.
95%.
Yes, they will end up with a live baby. Okay, it's only 5% where the baby can have a stillbirth. So we call it as stillbirth or intrauterine death, IUD. So what happens? My own younger sister had, though I was an obstetrician there. Imagine. So it is like the main thing what we say the patients is once you have crossed 28 weeks. The only indicator for us to know whether the baby is healthy or not is a DFMC, daily fetal movement count. So just if you keep concentrate on the baby movements, then the baby will be fine. Sometimes what happens when we are working mothers or when we are busy in so many other work, we don't concentrate on the baby movements. So you will not have baby movements for say one full day. They don't realize. Then in the night when they are about to sleep, they realize, oh, I don't have movements at all. Then when they come, sometimes unfortunately the heartbeat is not there. But if you find out, within 2 hours I don't have movement, and if they come, then definitely we can, identify at the earliest and we can do something. Recently I had 2 days back, I just delivered one mother. She was around almost 36 weeks, 35-36 weeks. Baby was growing very well till 28 weeks. And then at 32 weeks when we did the scan, it showed a IUGR, that is intrauterine growth restriction. Yeah. So the baby is not grown. From 1.5, in that 4 weeks, it is grown only 100 grams. So 1.5 to 1.6. Ideally, it should have grown at least 800 grams.
So it has to grow 800 grams every week?
Yeah, 200 grams every week, ideally.
200 grams every week.
Correct. So it should have gone at least 800. This is grown 4 weeks, only 100. So then the baby is come 1.6. Then I told her, okay, you come once in 2 days. So she was supposed to do her scan after 1 week. But some intuition, I told her, no, 1 week. In 3 days you come. I'm getting goosebumps. 3 days she came. There was no liquor. The water around the baby.
There was no water around the baby.
There was no water. It's all fully dried up. Then we had to admit her, emergency. We had actually prepared her 2 days back only with all the steroids and all. Then we did an emergency. When we did a cesarean, full meconium. The baby is past full motion. If we had delayed only by 1 day, then like what you told, stillbirth.
The baby swallowed the meconium.
And and there's no liquor. The baby can't survive when there's no liquor. So there are so many factors for the baby to come to, have a birth, whether it's normal or cesarean, to come as a live baby. The water content should be good. The baby's weight gain should be good. There should be good amount of the nourishment for the baby. So these are the factors which is
should be considered.
Yes.
So we talked about the final outcome, stillbirth. But there are multiple people who did not proceed with the pregnancy even more than 12 weeks.
Yes.
Right? Multiple abortions happening.
Yes.
Either it could be natural or, that could be they had like bleeding all of a sudden. And then they go in, they say that, the embryo is not anymore. What is the most common cause of this?
Okay. So most commonly it is something called as this APLA, antiphospholipid antibody syndrome. That's a very common condition where we have antibodies against our own body. So our body will develop antibodies against our own body. So it is called as immunodeficiency condition. So that is one of the conditions. Other than that, then it can be like sometimes consanguineous marriage can have abortions. Sometimes when you are having thyroid levels are very high, that can lead to abortions. And other infectious diseases, though they're not very common as before, but toxoplasmosis and syphilis.
Some infections.
Yeah, infections. All these things can be the reasons. Sometimes, you will not have any reason. But we'll do all these tests and we'll find all of them are negative. But still you can have an abortion. That is unexplained. So that is one big chunk where you don't find the reason. And then these are the most common. But mostly it is autoimmune conditions.
Autoimmune condition, yeah. I'm going to expand on the consanguineous marriage. See, consanguineous marriage means you are marrying within your family.
Yes.
It could be your sister's daughter or uncle's son, uncle's daughter, with the first degree relatives.
First degrees usually doesn't happen. From second degree they come. Second degree is a mother's side.
I'm sorry. Yeah. Second degree.
Second degree. Mother's side. So when you're marrying your mother's brother for a girl, so mother's brother, that becomes a second degree. So what happens, and father's side, usually we call it as a third degree. And then somebody in the relatives, uncles, some like that and all, then it becomes fourth degree. So second, third, and fourth, most common what I see, especially in Chennai, when I see, most of them are second degree. Most of them would have married mother's brother.
Mother's brother.
Yeah, because old at that
Correct.
time and all, they will have both will, mother and daughter will deliver at the same
time.
Yeah.
Correct.
So then most of the time the second degree what we see. So here what happens, sometimes they can have anomalies. So most of the time they'll have these anomalies which their mother may not have, but their grandparents would have had. So it would have been a recessive. So both of them would have recessive. Now when you're marrying within the family, so here recessive and there recessive both combine together, that one baby can get affected with lot of anomalies, which can be a structural anomaly or it can be any other chromosomal
like
anomalies.
birth defects.
Yes, birth defects and all. Abortion also can happen in these individuals when they have any of these chromosomal problems. So then, it is, but if we do the chromosomal study and we identify what is the problem, then it is easy for us to change it. Yes. Only problem with abortion where recurrent it happens, is this autoimmune disease.
Yeah. So I'm an example of the consanguineous marriage.
Oh, okay.
My dad married the sister's daughter.
Okay.
Right, which was 40, 50 years ago. So then I was born with this short little finger. You see that?
Yeah.
Okay, so this one my father had, my grandfather had. So we were
boys, huh? All
boys, even girls as well.
Oh, even the girls
as well.
Okay.
So it was thought that it was a lucky finger, and maybe that's why they thought I topped the school.
That's nice.
So
then,
then
everybody has it in the middle finger.
Not necessarily. It could be other fingers as well. Fingers as well. So then I married Priya as my wife. She's within the community, but not consanguineous.
Okay.
So we got married, and then first pregnancy, 12 weeks abortion. Second, same thing.
Okay.
Third, same thing. Then we thought, as usual, any Indian community, if you are failing 3 times, the fault is in the wife.
Yes, girl. Always.
Girl, always. Boys
not only abortions, even infertility.
Infertility.
Problem is only girl.
The boy cannot have anything. So then, she has some history of PCOS in the past, and we thought, okay, so there could be some reason. The fourth baby was also conceived. It went up to like 24 months.
Okay.
24 months.
24 weeks.
I'm sorry. 24 weeks, correct. 20 to 24 weeks. And then in the anomaly scan, what happened was the baby did not have any limbs. Okay. No arm or no hand, no leg. So at that time, it was a very shock to us. It was like the fourth month. And then we were like, okay, so why is this happening? So then I realized that, okay, there is something genetic is going on. So that baby was delivered around 24 weeks as a normal delivery because they didn't survive.
Yes.
So we sent the baby to the analysis. You'll be surprised that they had the same genetic defect. Like exactly what you said. One gene from me, one gene from my wife.
And that
combined together, dominant to the point that it was not survived. So since then, I have been promoting to all people to marry outside the community.
Correct. Love marriage is better. No, don't love within the family also.
To marry outside the community, because I think the concern is that, okay, you marry within the community, you just keep everything within yourself. So, and then after that, when we were blessed with 2 beautiful sons, we biopsied them, and then they did not have the chromosome.
Okay.
Abnormality. So that's why they progressed.
Okay, the
next pregnancy. Okay. And then the pregnancy after had the same chromosome.
Yeah, because see, no, XY, XX. So then it happens like, you can have 4 different combinations. So in one, when you become pregnant for one time, it is 4 different this things. So which one will grow? So in that, the sex of the baby also is determined by that only. So XX, XY, XX, XX. So it's 25% chance of this thing. 75% chance that you may not have the problem.
If I mean, it was very traumatic at that time, and now we are, since we are blessed with two sons, we were like, oh, good, something.
Overcome that,
We
yes.
overcome that. What will you tell a woman who's going through these
I
miscarriages 2-3 times? The mental state, I can't even imagine.
It's bad. It's really difficult because I had a mother. They came from, I think, Andhra. Okay, so she had seven miscarriages. In that, like, first three were happened at in the early stages, 10 weeks, 12 weeks. Then at 24, then this thing. They were also consanguineous marriage. So then they came to me with after 7 failed. They're like, and not well to do also. So when you're coming to a corporate hospital, it's difficult for us, to this thing. But then, somehow she became pregnant. I kept her in the hospital, like, thanks to my hospital administration.
They let them in?
Yeah, they let them. And, we kept her till she was around 12 weeks, 20 weeks. And then we found a house for her near our hospital itself, near Sims Hospital. And then she was staying there. We used to take our ambulance, and she used to come in the stretcher. She'll come, she'll do scan in the stretcher, she used to go. And, we did all the tests, whatever required. She went back with the baby after, I think, after 7 miscarriages. Miscarriage or late, even IUD she had after 7th month, 8th month.
Death of the baby inside.
Yeah. So till she got the baby, she didn't know that, that she will have the baby. And after first birthday, they just celebrated. So every year they come, they come, they'll with the baby and all those things.
Nice.
So it is really, but there are people who suffer like this, 7, 8,
But
sometimes. Outcome is good. If you taken care properly. See, that care is required. Sometimes what happens when they are in a small place where they don't have the access to the facilities, because you have to give that special care, we have to give some special medicines, injections, and all those things. So if you have the access to a good care, you can have a healthy baby.
So these are called high-risk pregnancies.
High-risk
pregnancies. The risk is,
we call it as recurrent pregnancy loss. When it is more than 3 loss, then it is called as recurrent pregnancy loss, which requires a high-end care, tertiary care center, with all the scan facilities, all the the newer medicines. There are so many options which you give to them, and they have to be with you. Throughout their journey, they have to be with you.
Close supervision.
Yes, very close supervision.
Very close supervision. So we talked about getting pregnant after 12 weeks and then abortions and everything. So now I'm seeing increasingly common is, especially in the US, there is a pill called Plan B. Yes, when they have unprotected intercourse and they don't want to continue with the pregnancy, Plan B is something that is mildly available in the US. I heard that there's something like I-pill in India. What is that about?
Okay. See, I-pill is a pill which is used immediately after a unprotected intercourse. Okay, but that is not a good contraception method, and especially in India at present, in Tamil Nadu you will not get any I-pill. Okay, because it is banned. You're not supposed to use, because what happened is people started just randomly using it. You have intercourse today, tomorrow they'll take. After 2 days they'll have an intercourse, again they'll take. So then your whole hormonal system becomes totally upside down. Okay, so then once you use the pill, it's a hormone, it's a contraception pill. It's a progesterone pill. Okay, so what happens once you take that? After 2 days you get withdrawal bleeding. And then again after 2 days you have an intercourse, and then again you take, again you'll have withdrawal bleeding. So you don't know when your actual menstrual period is. So then it causes a lot of side effects. It is not 100% foolproof that you will not become pregnant. No. You may become pregnant even with that. So what happens, sometimes people think that, I had an intercourse, but I took the pill. And if I don't get my period, nothing will happen. But then they will come with 8 weeks, 10 weeks, where you cannot do a termination of pregnancy also without the medicines. So then it becomes a problem. So I-pill at present we don't prescribe.
We don't prescribe.
Yes, we don't.
Are you seeing increasing DNCs these days?
I should say that I see increasing number of people coming with unwanted pregnancies. The number is increasing from what it was before.
Give me a percentage. 10 years ago, how much percentage, and now how much percentage?
Percentage, if I see,
Like 100 people.
Yeah, out of 100 people, maybe it was around 10% before. Now it is around 25 to 30 also.
1 in 4 people.
Yes, 1 in 4 people. It is 2 category of people. One is the younger chunk who are not married, and then they come with the unprotected intercourse and then pregnancy. The other is the elderly 35 plus who have completed their family but they have not followed any contraception method, and then they come with the pregnancy and they want termination. So it is a two different category of people. So but both of them come with the same this thing that they want termination. So ideally, if I should tell, termination is okay, but should be done in a proper setup. You should do it in a places where it is certified. So don't do in a place where it is not certified. Go to a clinic and just take some pills from the doctor and take. Because what happens if it is not done properly in a younger age, especially if a little bit of products is left inside, your it can become infected and your whole uterus will get damaged.
So if you don't evacuate completely.
If something is left inside, it can lead to infection. Because of that, your cavity can get damaged, and in your future you cannot have a pregnancy. This is even with the medical method. So when you're coming to termination, if you ask me, there are two things. One is medical. You do only with the tablets, or then you do a procedure which is a DNC. Or what we call it as suction evacuation in our terminology. Okay. So when I'm coming to medical, it is to be done less than 7 weeks. Okay, less than 40. Once from your last period date, within 49 days, if you come and see a doctor, then you can do it with only tablets. After 49-50 days, then you have to go for a procedure. So when you're doing this medical method, you cannot just go tell I'm pregnant and take the tablet. You have to do a scan, confirm that the baby is inside the uterus. By chance you have not done a scan and taken the medicine, and if the pregnancy is in the tube, ectopic pregnancy, then you take this medicine, the tube will rupture. Then it is life-threatening for the mother. Because they come to the clinic, doctor, without doing anything, please give me tablet. No, you should never do that. You have to do a scan, confirm that it is an intrauterine pregnancy, and then take the medicines. And then there is oral medicine, there is a vaginal medicine, and then within 2 weeks, once you do a scan, everything is cleared. So if it is not cleared, then that time they will do a procedure. And then when it is coming to the procedure, above 7 weeks, up to 12 weeks, you can do the DNC.
Actual procedure.
You
put in a small probe inside.
Yes. We put a small speculum, we hold the cervix, and then we put a probe inside and curate the material out.
Extract.
So nowadays we don't do too much of curettage, because when you do too much curettage, the studies have shown that it will damage the lining of the endometrium. So then that Asherman syndrome, where the two cavity they become fixed to each other, and then the next pregnancy it will be difficult.
Correct.
Or then if you held the cervix for long, if you've done too much of dilatation, the cervix becomes short, cervical incompetence. All these things can happen for your future pregnancy. So what we do now is suction. So there is a suction machine. So we just put a cannula there and we suck the contents out.
Instead of scraping out.
Instead of scraping. So when you're doing suction, your cavity is safe. You will not affect the lining. And we do it under ultrasound guidance. So you see how much is required only and you do. So that is a safer version. But then because it is safer, you should not do it again and again and again. Once you have done, okay. If you completed your family, please do the sterilization. If you're young enough, then there are so many contraception methods, It's very easily available also. So you can use that.
So you're telling me in Tamil Nadu, there are centers that are not certified doing this?
I'll not be, what do I say?
There
are people, there are people who they in a small center, they just go and they take tablets and they do that. But ideally, you should not do that. You should always do only in a certified
center. How do we know it is certified?
In any hospital which is more than 20-30 bedded, will get the certificate. Will get the certificate because they have the infrastructure. So why you should not do this medical termination in your clinic is because suddenly the patient can develop too much of bleeding, and you don't have a safety measure there. You cannot put IV line there. So that is why you're not supposed to do it in a clinic, because suddenly the patient collapses. Then what will you do? So
have you had any patient transferred to your center with similar kind of?
Yes, we had one. I think this is maybe 2 years back, where she came from a remote place where they tried all different types of medical methods, and by the time she came to us, she was almost around 16 weeks. So she's crossed the 12 weeks also. Then they came with full high risk. So when they come, and full infection and all those things. So when they come like this, you can't try the medical method and all. Then you have to take them to the theatre. We give antibiotics and everything, but with the extra consent, telling that we may remove your uterus.
Oh my God.
That is very dangerous, especially when you're not completed your family. If it is infected, no, we cannot save that uterus. Imagine the whole uterus is infected. To save the life of the mother, you will have to sometimes remove. But luckily for that patient, we could just take the baby out and clear the this thing, and she's had a baby after that, so she's good. So we do get reference, but not like before. When I was as a student in my medical college, we used to
You
see
see
a
so
lot
many,
of
right?
cases. Yeah, we used to see a lot of cases. But now it is reduced. Reduced.
I should take it back. I think gynecology is better than gastro.
Yes.
Purpose of the podcast is to actually explain to the audience in terms of, like all pregnancies doesn't necessarily mean a successful outcome. So you should be careful and be aware of all these high risk things, right?
Correct.
So one of the high risks that I am seeing these days is smoking among women. To be honest, when I was in medical school here in 2005, 2006, I've never seen smoking in women that much. In your practice, among pregnant women or even gynecology, how common is smoking in women?
Not very common, especially, but we do get sporadically few here and there. But alcohol is a little bit more common
Is it right?
than smoking. Yes, but we do get. Today I had a patient who came. She's actually, she's working in US. Then she came and asking me, she came with the mother first. So then the mother went out and she wanted to talk something. Then she's like, doctor, I drink and, sometimes I smoke. So I'm planning my pregnancy. What I should do? So there are, people, the incidence is more. The prevalence is more if you see people with smoking and...
Why are you saying in US? In Chennai also same thing?
Chennai also. The influence is
Influence
there.
is transmitted.
From there, the influence is transmitted here, and people, it is more. It is more. And so when they come, so we tell them definitely no to both. You cannot smoke.
So no
and you
alcohol.
cannot. Yes.
Even when they are trying to conceive.
Yes. 3 months prior, smoking and alcohol, definitely you have to stop.
Social drinking.
Social drinking, that's the next question they'll ask, but not for a woman. Not if you're planning a pregnancy. Then they'll ask whether we can take any other, particular wine or something like that. See, nothing is safe. You never know what is safe, what is not safe. So best is to avoid. Because you need to have a healthy baby. That whole baby is dependent on the mother. What enters your blood will enter the baby. So why expose the baby to because alcohol has got a certain side effects on the baby.
So what happens if the pregnant woman drinks alcohol?
Okay, so the baby can have IUGR. So what is IUGR அப்படினா baby's growth restriction. So baby it will not grow to the same extent as that of the what it should ideally grow. So ideally the baby should be anywhere more than 2.5 to 3 kgs. So when the baby is less than 2.5 kg, then we call it as a growth restricted baby. So then once the baby is restricted growth, the baby will have, you'll get a 2 kg baby or a 1.8 kg baby. Very thin, very small. You can't handle the baby, first thing. Second is the baby's immunity is low. The baby will acquire all the infections faster. The baby will be kept in the NICU for 1 month, 1.5 months. All unnecessary problems. Human, yes. That is human generated problems. It's not necessary to have those problems.
It is a modifiable risk factor.
Yes, modifiable risk factor. Fully.
Fully. You mean fully?
Fully.
Not that fully. How about stress levels, ma'am? Many people are working in IT. I see many women working in the night times according to the day times in the US.
Yes.
How is that affecting the pregnancy?
Yes, it is. That is also a major risk factor now. If you see, the IT risk factor is too much because it's not only during pregnancy. For them to conceive also, the whole sleep cycle is disturbed. So they come so we tell them, morning you get up at 8 o'clock, have your breakfast, then your all this meal plan. Then they tell, no doctor, I'm sleeping only at 8 o'clock. So then what to do? So the whole system is, it is very difficult because if they can't sleep for 8 to 10 hours of sleep in the night is very essential for you to have a healthy baby. and you should have at least 2 hours of sleep in the afternoon. No, it's not like, sleep. It is like just lie down in the left lateral position. So at least when you're lying down for 2 hours in the afternoon, 8 hours in the night, the baby gets good blood circulation. So it is like when you're sitting, the baby will not get the blood circulation what is required as when you're lying in the left lateral position.
Why on the left side of the
Yeah, why left lateral is very important. So once the baby grows more than 20 weeks above the umbilicus,
5 months.
Yeah, 5 months above. So what happens behind this is the uterus, and here is your spine. So in between the spine and the uterus, there are the inferior vena cava and superior.
The large blood vessels.
Yes, the large blood
from the
vessels. The aorta and the vena cavas. So when the uterus grows, it compresses the aorta. So when you're sleeping in the straight position. So if you're compressing the aorta, the blood supply to the uterus is reduced. Hence, the blood supply to the baby is reduced. Again, the same terminology, IUGR or low birth weight. The baby will not grow. Okay. So for the baby to grow, when you're sleeping in the left side, the uterus is tilted. So the aorta will have good amount of blood flow. You can ask why about right. So when you sleep, right is also okay, 10%, but 90% left. When you're turning to your right, there will be partial compression on the aorta. So, but minimally blood will be going.
It's better than the supine.
Yes, it's 100% better than supine. But there's one more myth about this left-right. What mothers will tell their daughters, every time you change the position, you have to sit and then change. But that is a myth. It's not required. So from your left, you can become straight for 5 minutes and then you can turn to the right. Maximum left, but no need to get up every time and then, change the position.
I see. If you sleep on the left, it's a male baby?
No. All pregnant mothers, we tell them to sleep on the left only. So there's no left, right. There's no male baby if it is the position. The shape of the abdomen doesn't indicate.
Shape of the abdomen people consider,
Yes. They say if the abdomen is very much visible, then it's a girl. If the abdomen is not seen at all, then it's a boy. And the funniest part is they'll come with a heart rate. My patients will ask, doctor, what is the heart rate? I'm like 140, 146. Then their husband and they'll have a eye-to-eye movement. Like, what happened? No, then it's a boy. So that is a myth. The heart rate for any baby is between 120 to 160. So it varies. So today I see 120, tomorrow it will be 160. So today girl, tomorrow boy. How can it be? So there are so many myths. It's fun actually.
In US, it's very simple.
They say, 6 weeks, yes, you are having a girl. You are having a boy.
So in the US, it's the responsibility, it's the option for the mother to tell the dad.
Oh, okay.
They don't tell the dad. So they just tell the mom.
Okay. So she decides.
I have seen so many cases where the dad doesn't know anything. The mom knows.
That's also nice.
So the dad gives a surprise baby shower thinking that, okay,
it's a boy or a girl.
And then mom knows, why are you spending this money? It's a girl. Anyway, so if you are pregnant, what is one nutrition advice that you will give to the pregnant lady?
Take good amount of protein in your diet. Protein is very essential because especially when we are in down south, maximum our diet is all of carbohydrates. We eat idli in the morning, we eat rice in the afternoon, and we eat dosa in the night. So it's only carbohydrate. Protein is very essential. So if one advice, if you ask me, I'll tell protein. If you are a vegetarian, soya chunks and all those things. If you are a non-vegetarian, fish, egg, and chicken.
Chicken.
Yes. Other than that, multivitamins, if you are asking me, vitamin C rich food and iron rich. So vitamin C, any of the kiwi and all citrus fruits.
I have a question on prenatal vitamins. We are not planning, I'm just asking you.
Okay.
Prenatal vitamins, people start taking it even before conception, 3 months before. Is that what the recommended thing is?
Yes. Because mainly to prevent these neural tube defects, you have to take this folic acid. Mainly it should contain folic acid. But the prenatals, what we get it in US, it has this vitamin A, which ideally we should not take. Vitamin A is not, it's contraindicated in pregnancy. So main thing is folic acid.
Folic acid is
Folic
the main
acid,
thing.
yes.
To prevent the neural
tube defects,
So if there is a vitamin A in the ingredient, it is better not to
avoid,
take
yes.
it. I see. And how long they should take it? 3 months?
3 months. First 3 months.
After conception?
After conception, continue for first 3 months of your pregnancy till 12 weeks.
So 3 months before and 3 months after. 6
and
months.
6 months. And then we change to iron. Na? So this iron also will have folic acid. So they get folic acid throughout 9 months. So folic acid is required the whole 9 months.
One of the other common condition we are moving away from pregnancy is endometriosis. Okay, I thought PCOS was a very common diagnosis, but after talking to many OB-GYN, I'm realizing that endometriosis is also getting there equally. Can you tell us if a woman has irregular bleeding, either excessive bleeding or decreased bleeding, is that what endometriosis is?
So endometriosis is it's like, you can have cancer, but you should not have endometriosis, because cancer is curable, but endometriosis is not curable. Okay, it's a very unfortunate to see young girls who get endometriosis. So endometriosis can come to anybody. The symptoms can vary, like how you told. They'll have excess bleeding, or they may have severe pain. So what happens? Why endometriosis? Why me, doctor? They come, why me? Young girls we see at 18 years, 20 years. Some people get endometriosis after 40, but some people, they get at 20 years, 22 years. So it is a chromosomal problem. It is not because you have had abnormal diet, or you don't have a proper lifestyle, you have not slept properly, you have not ate properly. It's not. It's not in your control. It is destiny that you are supposed to get endometriosis. So what are the symptoms they can have is, in a younger age, they'll have the severe pain, the dysmenorrhea, what we say. They'll have severe pain, which can, 2-3 days prior to their periods, and then during the period, and it can last for 4 to 5 days after their periods is over also.
Oh my God.
So that is a pain what they'll have. And it's excruciating pain. Because of pain, they cannot go to their school, college. They'll have nausea, vomiting, all the symptoms.
But there'll be these symptoms may be normal as well around the perimenstrual period.
Yeah, it can be normal, but the intensity of the pain, if the intensity of the pain is very severe, then we have to keep it in our mind that endometriosis could be one of the differential diagnoses. And then these people who are having excess bleeding. So what happens in endometriosis is, so there is a uterus from where the blood will come through the vagina. So here the blood will go in the retrograde direction. So the blood will flow. The 50% of the blood is coming through the vagina. It is coming out. Another 50% will go in the retrograde through their fallopian tube, and through there it will come and enter into the
ovaries.
Pelvis. Yeah, pelvis and ovaries. Yes. So the ovaries are there, right there. So it will fall on the ovaries. So that it causes ovarian endometriosis. Okay, that is called as endometrioma. And then these blood tissues can fall on pelvis anywhere. So then we call it as pelvic endometriosis. It can also fall on the intestine, which is all nearby. So then it becomes a problem. What happens is, so blood is getting collected every month. So it's a small cyst. Then next month it will come, it will increase. So when it becomes grade, it starts with grade 1, 2, 3, 4. So grade 4 is when the whole of the ovary is enlarged and it is kissing each other. It's called as kissing ovaries. Okay, the two ovaries are fixed. The uterus is fixed here, and all the intestine surrounding are all become fixed. So it becomes a frozen pelvis. Wow. This is endometriosis, which is very difficult. If it is identified early, there are luckily we have a lot of medicines and options available now, which if identified early, we can, at least prevent them to going to this grade 3, grade 4.
So let's say I'm a 24-year-old woman and I get my cycles like once every 28, 29 days. First month I'm getting around, I'll bleed for like 3-4 days. Now I'm bleeding for 7 days. First month I didn't make a big deal of it. Second month is also 7 days. So when should she come and see you?
So if you see what is normal, when a lady is having anywhere periods between 24 to 35 days, it is normal. Okay, and when you're having a bleeding,
so 35 days is also normal?
Yes. 35 days is also normal. It's not necessary that you have to get your period every month. It's a myth. There's no need. You can get your period 24 to 35 is a normal cycle. First thing. Second is the bleeding. The bleeding 3 to 5 days is normal. Normally you change around 3 to 4 pads per day. There should not be any clumps, that clots. That should not be there. First day pain is normal. Anything out of this box. So you're getting a period pain for more than 4-5 days after your menses is over, or your pain is coming prior to your period's onset. You're changing more than 6 to 7 pads per day. The pad is fully getting soaked. You're having clots, clumps. And then you are having a bleeding for more than 6 days, 7 days. then it is a time that you have to go and see your doctor. Even if it is the first time, at whatever age, please go and consult a gynec, because it can be a precursor for endometriosis also.
Okay.
So this is the time you have to go and see your doctor.
Okay.
Then what we basically do, first thing what we do is we do an ultrasound. So in a younger girls, we only do a transabdominal. But if you're married, then ideally we prefer a transvaginal scan, because that is the best. So then you do a scan, we find out what is it. If it is not endometriosis, very good. Then we just give you symptomatic medicine to reduce your bleeding, to reduce your pain. But by chance, if we identify that it is endometriosis, we can treat it then and there. And then, you can prevent it from growing it to grade 2, 3, 4 like that.
Nice.
That is a best time to identify and treat it.
I'll tell you a scenario. Patient I saw. This patient has left-sided abdominal pain.
Okay.
Each and every time during her menstrual period. Okay, 5 days. And then after the period is gone, she completely normal.
Yes.
She came to me. Multiple testing done, CT, abdomen, everything is negative. I do a colonoscopy. I see these endometrial spots in the sigmoid colon.
Correct.
Then we track back, and then they say that I've been bleeding for like 7 days. That's been my norm in the last I thought it was thyroid. Thyroid can cause prolonged bleeding, but only when it is high, correct?
Yes.
When it is low, it
will cause hypo.
decrease.
Yes, it will decrease the bleeding. And again, thyroid, when it is too high only, if the TSH is say 10 and above, that is the time when it will interfere with your menstrual cycle. It's not like, your thyroid is 5 and because of that thyroid my bleeding problem. No, it's not like that. It's only like, and this
significant.
Yes, it's not. It's significant only when it goes more than 10. Yes.
So let's say that you try medical options and then the patient don't get better. Then they come to you and you were an expert in robotic hysterectomy. Can you explain to your audience what is hysterectomy and what is robotic and all those things?
Okay. So hysterectomy we do once you have completed your family, and then it can be for various conditions.
Hysterectomy
so
is
what
uterus,
is hysterectomy?
uterus removal.
Yes. So what is hysterectomy is basically we remove the uterus. So uterus can be removed by an abdominal incision that you put like a cesarean, no? We put a cut on the abdomen and then we can remove. Or we can do it by laparoscopy, both, or you can do it by robotic, which is the latest. Both laparoscopy and robotic hysterectomy is minimal invasive. Okay. So first thing is who all require hysterectomy. Okay. So any woman who's completed your family, you are above 40, the condition is absolutely required to remove your uterus. Like you have large fibroids where there is no medical method. And removing only the fibroid at the age of 40 is of no use, because at 45 it will again come back. And then you have to do a major surgery. Or adenomyosis, like how endometriosis, where the blood gets collected in the ovary and in the pelvis. In adenomyosis, the blood will go in the reverse direction and it gets collected within your uterus. So your uterus becomes bulged. Okay, and again it is the condition where there is severe bleeding and where there is severe pain after the age of 40. So adenomyosis is one more condition. Sometimes only hormonal imbalance can have enlarged uterus, and then endometriosis is one more condition where we remove the uterus. So now if you ask me, obviously open method, there are a lot, your healing is a little delayed, you're there in the hospital for more days, you'll be almost bedridden for 5-6 days. And then,
open is you take a surgical knife, you make an incision, and then you open the abdomen.
Yes,
that's
you open the
surgery.
yes. You put a 10 centimeter incision and then you open the abdomen in different layers, skin and then muscle and then rectus sheath and then peritoneum, and then you enter inside. Okay.
Did you pass out on your first surgery? No.
No, but I did. Not in my when I was doing the surgery, but when I was assisting, yes.
Yeah.
2-3 times I have.
No, me as well. First assistant surgery, when I saw the blood, I was like, that's why I decided not to become a surgeon.
Okay. I passed out, I think, because my surgeon was, he was doing it so fast and I was like tensed, what is happening? And then I was like, sir, I'm feeling giddy.
Amma, who's the patient here?
I know, please.
Okay, so open is that.
Open is that. So now when it's coming to minimal invasive, so either it's a laparoscopy or the latest is a robotic. So if you ask me, so in this minimal invasive, we put a 1 centimeter incision above the umbilicus, and then there are 2 5-millimeter incision on the sides. So what is the difference between a laparoscopy and a robotic? Okay. So in a laparoscopy, we put the instruments and then I perform the surgery. So the movements is like, it's so much of variation in the movements. And then every time you put a new instrument, you take it out, because to suction you have to use an instrument, for cauterizing there are so many different instruments, it keeps going in and coming out. So that port where you put the incision, the port side pain is more. So now when it's coming to robo, what happens, we fix the arms. Okay, so the two robo arms are fixed, and then it is not removed. So with those two arms, then I sit in front of a console, and then we put a 3D glass. Okay, so the view is like, you have the 3D glass.
What are you talking
and
about? You look like a gamer.
Yes, you look like that. So my son saw me doing this. Mommy, I think I also can do this robotic surgery. He came because he's a very good gamer. Yeah. So he saw me doing that. So it's almost like that. So you have only 3 buttons in your hand, and then in front of the console, it is 18 times magnified.
Wow.
The vision. So the uterus, which is so small, can be seen, so much magnified. So then when I'm doing the surgery, so I just see the TV and we do, and the robo is connected there. So the myth the people is, the robo is doing the surgery. What if the robo removes all my structures in the abdomen?
They're thinking that they'll turn the switch on, and then robot goes, and then say,
And the surgeon is not there, and then the robo is doing the surgery. It's not like that. It is a human controlled robo. Okay, so if I stop doing here, the robo will stop. If I do, the robo also will do. For so far, the technology is only that much. Maybe in future it will come. We don't know. Okay, but for so far, it is very safe.
Oh, nice.
And the precision of the surgery. Okay, so in a
Accuracy.
lab, accuracy is too good. So in a lab, I cannot move more than this. Okay, my hand will not go like this. But in a robo, you can move your hand in any direction. 360 degrees I can rotate. So sometimes when you're doing a posterior wall of the uterus in the pelvic region,
Difficult cases.
very difficult cases, especially in endometriosis, or when there is severe adhesions. Nowadays, if you see, most of them are previous to cesareans. So there are a lot of adhesions. So in these cases, when you do, because of the magnification, the damage to the nearing structures, the ureteric damage, all those things are almost zero. Blood loss is zero. So a patient will come with hemoglobin of 7. Still, we don't transfuse blood. We directly take them. We do the surgery. Before and all, what? We have to get
transfuse.
9.5.
2-3
Others,
units.
anesthetist will not give fitness. So he'll tell, no, not fit for surgery. Here, 7 grams, okay, robotic, finished, done. So if
Blood
you
loss
see
is minimal.
no blood loss at all, hardly less than 10 ml. Because, the robotic instrument, it is only say 1 to 2 millimeters is the scissor size. So with that precise instruments when we do, the structure, the damage to the neighboring structures is not there. So from the surgeon point, and I'm sitting and doing the surgery, there's no fatigue. Any complicated case, even if I'm doing for 3 hours, there's no fatigue to the surgeon. So from the surgeon point of view. From the patient point of view, because once the arm is fixed, it is not removed again and again. So there won't be any port site pain. So post surgery, within 6 hours, we remove the urinary catheter out. 12 hours, we make the patient walk. Imagine for a hysterectomy where we have removed a
Huge uterus.
whole huge uterus. Sometimes the uterus can be around 24 weeks size, large fibroid. Still, after 12 hours, she's walking. Next day morning, tata bye-bye, she'll walk and she'll go home.
Wow.
And with 3 days, she'll take rest at home. Within 1 week, she is back to her office. If it is a working woman, they can resume almost all their activities within a week. Only thing what I tell them not to do is, bend or lift anything heavy for 3 months. Because the vault what we have closed, that will take 3 months to heal. But from outside, you will not even know that they have undergone such a major surgery.
Beautiful. We talked about, pregnancies, deliveries and everything. So one of the most important thing that in the US, they are very concerned about is how they look after pregnancy. I have a strong feeling that, US women, they work hard on how they look, not because of health aspect, but majority in terms of how they look. They will work out, they will do anything that is possible to make sure that they look exactly the same as they were before pregnant.
Correct.
Okay. Some people, they don't want to put their hard work, and then they say, okay, I'll do the stuff. But at the same time, there is this term called Mommy Makeover, where they do for procedures,
Yes.
where they can tighten the skin and everything. Is that practice here in India?
Yes. So in gynae when we do, we call it as cosmetic gynecology. Okay,
The term sounds much better
yeah.
than Mommy Makeover.
Yes, aesthetic gynecology or cosmetic gynecology. But people come asking for mommy makeover. Okay, so what happens when you become pregnant and you have delivered? So changes happens. See, when you take cosmetic, now people will think only the face, but it's not like that. You know, changes happens at the breast level. So there is sagging of the breast. Then your abdomen, it becomes loose. It's like a balloon which is distended, and then it doesn't come back to the same size as before.
Correct.
So then, you know, it is fully distended. So how much ever exercise you do, if the skin is very loose, that skin cannot become tightened by your exercise, which needs some kind of, because you know, now if you had a 2.5 kg baby, that is fine. But if you had a 3.5 kg or a 4 kg or a twin pregnancy where the abdomen would have distended so much, you know, then they always will have that pendulous protuberant abdomen. And then when you're coming to the genital areas also, they can, because of the normal delivery, the vagina has become very loose. So what happens if the vagina is loose? There are few problems also, like, you know, they'll have the stress urinary incontinence. When they cough,
They can
when
leak
they sneeze,
urine.
yes, when they
Without
sneeze,
their control.
yes, without their control. When they're doing any activity, like, you know, for example, they're going to a gym, they're doing some weight training, then they can have this urinary leak. So it's a social embarrassment. But people don't know that, you know, you can correct these problems even without surgery, also with minimal treatment facilities. That is one thing. Then, you know, your prolapse of the uterus, prolapse of the bladder, that is, you know, it comes down from its normal position. So these are all the problems which happens post delivery. So as you told, if you have not taken care of your postnatal period, because once a baby is born, no, mother will, she'll become lax. She'll like, okay, baby is my
I'll take
world
some
now.
rest.
Yes, I'll take rest. No, I'll eat, I'll feed my baby, but I will not do any postnatal exercise immediately. Then after 1 year, she'll realize, oh my God, now I put on weight. Now what I will do? So now I want to come back to shape.
But I'll tell you, in that scenario, I feel bad for them. Okay, especially in the US, I'll tell you. I mean, it's happening in India as well. After delivery, we feed them so much.
I know.
To a point that not because of the women, it's for the growth of the baby.
Baby, yes. Baby wants milk.
Baby wants milk.
Yes. So mother has to eat.
Motichur
Whether
laddu.
I know. Ghee.
Ghee.
With ghee.
With ghee. All they need is for 400 to 500 calories more. So just look at from their standpoint. So they deliver the baby. In 2-3 months, they're just showered with all this love and food, and they just recovered. So they put on more
10
weight.
kgs. Especially if you see during pregnancy, they would have already gained around 16 kgs a minimum. Around 20. Plus they put another. So it's around 25 kgs to be lost.
And then there is this thing called in-laws will come over to the US to support the pregnancy. I'm sorry, mom and dad will come initially, and then the in-laws will come. This is a very common practice. 6 months, every 6 months we go back and forth. But sometimes, you know, they will not be able to come. So when they are not coming, there's no help at all. So
they have to do everything.
Everything. There is no way, to be honest, where, you know, if you look at them, okay, why are you not physically active? There's no way that they can do. They will be working.
Correct.
Because you need to work, 2 people will be working. And then they need to take care of the older kid as well. Kid as well.
Yes.
So I feel like the situation is not very conducive for them to
go and work out.
Take care of them. Postnatal care is very, very bad. Very bad.
Correct.
And while the damage is being accumulated, they get pregnant again in 2 years. Then the whole cycle is repeated. They come to 35 and they say that, you know, I did so many things, nothing is happening.
Yes.
So this postnatal care is very important.
Essential. Very essential. So what I suggest all my patients is, within 1 week, you know, you start the Kegels exercise. You know, Kegels exercise is very important. Once they start doing it, you don't have to take extra time. You're feeding your baby, you do the Kegels. You are watching TV, you do your Kegels. So your perineal damage is reduced. You know, the vagina can become tight without doing any much effort. Then, you know, you can do your upper body exercise also. You're watching TV, you don't have to take specific time. Simple exercises, we have to, you know, put it in their brain. But it is little difficult because I just fed my baby, I'm tired, I want to sleep. So most of the time goes in sleeping. So if they have not done all these things, so then the cosmetic gynecology comes there. So then, you know, we have an option for them.
So is it a laparoscopic procedure? What do you do?
Okay. So it is not a laparoscopy procedure. It is 2 things. There is non-surgical and there is surgical. So non-surgical is even without surgery. For example, the vaginal tightening, if I want to do. So I can do it without surgery also. So we have something called laser, or we have a radio frequency, or we have a Kegel Kegel's chair, where you just come sit on that chair, and this Kegel's exercise which you do normally, the chair will do that for you. So you have to just come sit 15 minutes and go. And that chair itself will do, it's like a MRI machine, magnetic resonance.
You have that in your clinic?
Yes, we have it in my clinic. So you just come sit, you can watch a magazine, you can watch some TV, and sit and go. So you have to come around 3 to 4 10 sittings every 3 to 4 days. And you come sit and go, your vagina will be tight. So you're leaking urine, it will reduce. SUI, that is a very good treatment. Or we do laser. So laser is also a very simple procedure, office procedure. In between your break hours, you come, do the procedure, hardly 10-15 minutes. You go back to your normal routine. So 3 sittings you have to come. And now we have something called as PRP also. So you have heard PRP for face, PRP for hair. So we have PRP for vagina also. So where we take your own blood and we make the platelet-rich plasma and inject it into your vagina. It causes vaginal tightening.
In the skin?
Into the vagina.
Into the vagina?
Mucosa, yeah.
Into the mucosa?
Mucosa.
What are you
So
talking
that
about?
is, yes. And I mean, there are so many other things. There's this G-spot, O-spot, where G-spot is
Correct.
like, that orgasmic spot. So they don't, that's a thing people will come, they want to give a gift to their husband. So then they'll come, or the wife, they'll come with the O-shot. So again, this PRP, we take and we inject it near the clitoris. So, that is also part of cosmetic gynecology.
Teach me here. So the G-spot getting
G-spot.
enhanced?
Yes. See, what is G-spot? It is just one point which is there in your anterior vaginal wall, maybe 2 to 3 centimeters in the anterior vaginal wall. So most of them, if you see, they don't get the orgasm, and they're not sure what is our orgasm. So then, when you give them this, that's a vaginal orgasm. Okay. So G-spot is, we take the PRP and we inject it into the anterior vaginal wall. So it'll just enhance that area. So then when they have intercourse, they get that orgasm. So that is, it's just nowadays it is more common. Yes, it's getting more common. People are aware of it and they come ask for it, which was, I think, only there in the US and in your place.
Correct.
So now it is more common in
I didn't know about
Chennai.
all this. But I am just surprised that so much technical advancements.
Yes, happening in Chennai. So this was a non-surgical. Then we do surgery. In surgery, from the breast, if we start, we do breast tightening, we do augmentation of the breast, or like if it's it's too big after delivery, after feeding, then we can do the mammo reduction. But all these breast procedures should be done once you've completed your family and once you have finished feeding the baby and everything. In between the feeding, you cannot do the procedure. So completed. And then when it is coming to abdomen, tummy tuck, you must have heard about that.
Of course.
In our terminology, we call it as abdominoplasty.
Correct.
So divarication of recti will be there. So we'll fix it, and then the loose skins can be removed.
But that is surgical, no?
That is surgical. So now I'm telling all the surgical ones.
Correct.
So that's a surgical. Then when you're coming to that mons pubis is too big, sometimes too much of fat is there. So then we can remove that either by a liposuction or by a incision and excise. Then the vaginal tightening. Then there's one newer terminology called as Barbie vagina. Okay, Barbie labia. So they want the vulva, the vulva and the labia majora. It becomes, as the age grows, once you become 40, 50, there is the fat in the labia majora becomes thinned out. So it's all become flat. So then they come at 40 plus and at 45 that I want the augmentation. So what you do, we take your fat from the abdomen. There's almost a lot of fat is there in everybody's women's abdomen. No? So we take a little, it is centrifuged, and then we inject it into the labia majora. Okay, so then you get a nice plump labia majora.
So those fat cells can be transferred?
Yes, can be transferred. And then it stays. For 1 year it stays, 2 years it stays. It doesn't disappear. So that is labial augmentation. Then we have this vaginal tightening, perineoplasty. So there are so many procedures. So, it's like before, it's only the celebrities and they will come to do all this. But now it's like a common people. We get people from, down south coming asking for these procedures. So common people are coming forward.
Good awareness.
Yeah, very good awareness. And it's not that, you should not do that. They have a lot of side effects. They'll come, why you want to do all these things. It is for a woman to feel good about herself. Okay, it's a feel good factor. You're not going to expose it to anybody. But it is for your happiness. So you feel confident from within, then you can, face the world also with that confidence. So it's just a feel good factor.
People from US coming?
Yes.
Because it is cheap here.
Yes, cheap here.
Very nice.
Cheap market. They come from US and they'll do the full mommy makeover and they'll go.
Mommy Makeover.
Full. In one sitting, we did for I think few patients, from breast reduction to abdominoplasty to labial augmentation, vaginoplasty, everything.
You need to do within 2 weeks because the next return flight is coming. We have booked already 3 months ago, very cheap.
Correct. They come full planned from there only online. Yeah, they come next day surgery. So then they are there for 2-3 weeks and then they go back.
Is there any daddy makeover or anything like that?
Yes, yeah, daddy makeover is there, but that is not, whether you're daddy or not, the belly fat it is there, we have to do liposuction. That is it, because pregnancy doesn't happen, no. So there's no changes happening in their body. It's only because of your food.
Changes are happening inside the stomach,
Yeah.
but not because of pregnancy.
Yes.
Not really.
Because of eating.
Because of eating. Super. Wonderful. Oh my God. Such a wonderful conversation. I'm going to wrap this up by
Great.
asking. Thank you so much. As a gynecologist who is so busy, how do you take care of your health?
Okay, so I am a very exercise freak. So I do exercise. I do Pilates. So Pilates is my favorite. So I do at least 15 minutes of Pilates every day. It's like one day I'll do abs, then core or something like that.
Online class? No.
I used to go to online, but now I do it on my own.
Okay.
So I do it on my own because online is little difficult to maintain the time.
Time.
So whenever I get time. So as I told, and then in the night time when I get free, I have a 1 kg or 2 kg dumbbells. So when I'm watching TV, I do my upper body because it's not necessary to be empty stomach for upper body.
Right.
So I do whenever I get time. So, and diet wise, definitely, I am a hardcore non-vegetarian. There's no vegetable in my house. But then everyday fish. Fish is a staple diet. I love fish because I'm from Mangalore. So I love fish. So definitely a lot of proteins in my diet.
What are you talking about? You're talking about a gastroenterologist with no vegetables.
Yeah, no vegetables. In my fridge, you will not find any vegetables. The
Fiber?
only vegetable comes to my house is potato. There's no other vegetable. So fiber.
How about fiber?
Yeah, fruits. Fruits. I take all. There will be all fruits in my fridge. So daily one fruit. Guava and all the fruits. I love fruits and dry fruits also. So I maintain a little bit of intermittent fasting types.
Nice.
So breakfast by around 11 o'clock, then finish dinner by 9. From 9 to next day 11.
You follow my channel?
I have to start following.
Even without following my channel, you were doing already this.
Already, good.
This is what I say in my channel.
Okay.
I'm so glad that you didn't open your channel.
Okay, great. Great. Yeah, I think I should follow you and see how to do that. Okay, what do you say? I'll start following for sure.
So what I say is that don't eat anything after sunset.
Okay. Okay. I saw today only I was just sorry. Today only I was just browsing. So I saw in that I think coffee ka one I saw. You and your wife I think.
Correct. You're like, who's this guy? This guy's a gastroenterologist. What is he doing?
But great, yeah, great. No, it's nice to have all the setup like this instead of having only one clinic. No, it's really nice.
No, I wish.
How did you get the idea to do this?
This one I came into accident. I came into a social media accident, and then I used to do stand-up comedy on the side as a hobby.
Okay.
So I combine both together, and I'm enjoying it.
Very nice.
This is my hobby, and I'm still a full-time gastroenterologist in US. I do all these podcasts when I'm coming to Chennai.
Okay.
And then that's why we have like 3 to 4 podcasts lined up. After you, there's another good
Somebody else coming. Oh my God.
Super. Thank you again.
Thank you
so much. You've been wonderful.
Thank you.
Thank you
it's
again.
Good, huh? Whatever I told.
That was a wonderful podcast. I absolutely loved it. She was such a nice person, sharing wonderful medical information to all of us. Before that, I want to make 3 announcements. Number 1, our podcast is being available in audio format and also in video format in Spotify, Amazon Music and Apple. Please look that link in the description. And number 2, because it's a 1 hour long podcast episode, many people have told me that this is too much for me to watch. So we have cut short, like highlighted portions, like 8 to 10 minutes, and published in a separate channel called YouTube clips channel with Gut Feeling with Dr. Pal. Please check that link in the description as well. We also have a shorter version with 1 minute reel being published in Gut Feeling with Dr. Pal channel shorts and reels, and that link is in the description as well. I also wanted to introduce to you my holistic gut health program. We call it as New Me. This is a very natural way to restore your gut health. I have passionately put this together, and I'm sure that the results that we are seeing in this program is phenomenal, because this is what I do in my California-based practice. We have found out a way to translate that into an online-based practice, so where everybody else can get benefit out of it as well. So if you're dealing with obesity, PCOS, hypothyroidism, fatty liver, or any kind of metabolic diseases, if you want to restructure your gut health, please check the link in the description and also in the pinned comment. It's just called New Me Health. If you need more information, it is in the website.